I do want women to know that there is an alternative to suppressing their bodies with hormones, that they can see their body as a good and they can live in that body holistically.
Totally. Oh my gosh. It's amazing.
Join co-hosts Jamie Rocci and Teresa Kenny as they educate women about the beauty of the feminine design and empower women to take charge of their health.
They're going to be so amazing. You're going to be so empowered by understanding your feminine genius and your hormone genius. I don't think I could live my whole life knowing this and not sharing it with anyone. Hello, everyone, and welcome to today's episode of the Hormone Genius podcast. Teresa and I will be interviewing Dr. Lynn Keenan today, and I'm really excited about this episode because the focus is going to be on sleep. And then so for those of you following along with the Hormone Genius long enough, you know, in my personal story, I have a total story, Dr. Lynn, with my own sleep struggles, specifically postpartum and postpartum, actually post-miscarriage. So it was a big struggle, and this is my own personal interest, so I'm excited to get to know you a little bit more today, Dr. Lynn. So Dr. Lynn, she's a retired clinical professor of medicine, and she's been practicing restorative reproductive medicine since 1999. She's trained in naprotechnology, which we've heard about before, of course, on our podcast, and also in neofertility. She was the director of primary care for a decade for the University of California, San Francisco, and then later created the Sleep Medicine Fellowship Program and was the program director for years. And she just loves this topic. She loves restorative reproductive medicine. And I can't wait to dig in more and learn so much from you today.
Well, thank you for having me, Jamie and Teresa.
Yes. So Lynn, let's just kind of jump in right from the get-go. Tell us why sleep is so important. And when you share why sleep is important, we know as listeners, we know why we need to sleep. But what do you think is something that women especially misunderstand about the importance of sleep?
Yeah, it's a great question because I think women tend to be those multitaskers, and if they're working and juggling a family, and they can get a lot put on their shoulders, and usually it's that, okay, well, I can sacrifice a little bit of sleep because somebody else needs me. But sleep is so important. It's been so misunderstood even in medicine. Why would we spend about a third of our life doing it if it wasn't important? And that's really where the healing happens. And so it's where a lot of the cells get turned over and healed, but also that's where like memory gets sharpened, mood improves. And so there's a lot of things that we didn't realize why it was so important to be sleeping. But really after I went through medicine at the time when there was still like 40-hour shifts, once or twice a week. And when I got into sleep medicine, I realized despite juggling work and 4 kids, it's like, oh, wow, if I want to keep my brain and, my memory sharp, I really need to make this more of a focus. And so it's what kind of changed me to make it a priority. And so it's getting back to those basics of, we know diet's important, we know exercise is important, and sleep is kind of the last one that people sometimes tack on. But I think that's something that we need to focus on more.
So, Dr. Lynn, sleep is something I think for women that's a unique challenge. And it's obvious that it's a unique challenge because women do something incredible, which is they give birth to other human beings. And so let's talk about through the reproductive lifespan of a woman, the challenges of sleep that occur. And Jamie's kind of highlighted one because for her, even going through such a hormonal shift after a miscarriage was a trigger in a sense for insomnia for her. How as women are we to understand the importance of sleep, but also navigate what appears to be kind of the natural course of a reproductive life of a woman is to not sleep? Do you know what I'm saying? So
Right.
How are we supposed to kind of navigate and really get that in the right kind of construct to be healthy?
Right. Because even women, when they have small kids, they're designed to wake up at a cry faster. They get a higher blood pressure response if there's a noise in the house. And so it's almost like we're programmed to be lighter sleepers. Like even when years of doing sleep medicine, and it seems like women always can tell you if their husband snores or not because they just wake up and it disturbs their sleep more. But the opposite is not true. It's kind of like, you look at the couple, okay, does she snore? And they kind of look like, maybe, and it's kind of like not a, and I think there's many reasons for that. I think sometimes men are just being polite, that it's not ladylike to snore, so they don't want to make a comment. But part of it is just this, we just wake up easier. And that more women complain, when they do population surveys, more women complain of having lighter and more broken up sleep. So it is part of kind of who we are, but it's taking that challenge to still make it a priority and trying to get, even if it's not all consolidated 7 hours, even if it's, 5 hours at night and you can catch a nap, which doesn't always work, but, kind of sometimes it does take some creativity. And also uh, when it comes to insomnia, it's making sure that you've got the habits that once you get in bed, you don't start thinking about things to worry about, that it's a peaceful spot and you have to really make that okay, it's a bit of a sanctuary spot to get the rest. Yeah.
Mm. So it's such an important topic. So let's say there are women listening and they think, but Dr. Lynn, you don't understand. Like, I'm trying to do all the sleep hygiene stuff. I'm writing down my to-do list, like before dinner even, so I don't have to think about my to-dos. I'm shutting off blue screens. I'm taking an Epsom salt bath. I'm trying to do everything I possibly can. What would you recommend these women do if you've seen them and they're doing all the sleep hygiene things, but they're still struggling?
Yeah, it's a great question. And I think everybody knows that you kind of start with sleep hygiene, but if you just give them a list of sleep hygiene, that doesn't actually change anything. And so it does have to be the first step. But in fact, it's funny because that's on just about every sleep boards is, does sleep hygiene change insomnia? No, it doesn't. And so it's, if they really have insomnia, then it does need the next step. And so sometimes it's another sleep disorder like sleep apnea. Sleep apnea will present as insomnia initially, when it's like if the body knows that something dangerous is going to be happening in sleep, like you're not going to get enough oxygen, that raises the blood pressure, the healing stops, it will like create insomnia. It's like a protective insomnia, that something harmful is going to be happening in the sleep, until the body gets so tired that then it just like sleeps through it. So sometimes it's digging for other sleep disorders like that. And again, like sleep apnea is so underdiagnosed in women for multiple reasons, kind of like the snoring, the men not wanting to complain, or they just sleep through it. But also that a lot of times it starts first in REM sleep, because we paralyze our bodies in REM sleep. That's when the airway is going to collapse, faster. So sometimes women don't even get the airway blockages that kind of define sleep apnea until they hit REM, which is the last third of the night, is where the predominance of it happens. Another reason why sometimes, men don't pick it up if it's just at the last part. So there can be other diagnoses. And so rather than just kind of stop, is it just simple insomnia? Sometimes it's good to be kind of evaluated for those other things, like restless legs. If people are iron deficient, they can get more restless legs, and that can certainly interfere with falling asleep. And then there can be circadian rhythm disorders where they're just programmed to want to sleep in and, stay up late, even if it's not just habits like, watching TV too late and whatnot. So sometimes it just needs a good review of all the other sleep disorders, because then no matter how hard you try the treatment for insomnia, if there's another root cause, it's not going to work. But then if it does feel like, okay, it's just simple insomnia, probably no snoring, or waking up with morning headaches, that's certainly another clue. If people wake up with headaches, then be thinking sleep apnea instead. Um, but for insomnia, the best treatment is the cognitive behavioral therapy for insomnia. And so that again, it starts with sleep hygiene, but really it's all the other things, the next steps that you do of like, what are you thinking about? Where are you going to give your mind a task when you're going to bed? Because our minds are problem solvers. So if you just say, relax, I'm not going to think about anything, well, immediately without control, you're going to go to problem solving. So you actually have to give yourself something to think about. And so like when we're counseling and when people are doing CBTI, they have to be able to list, okay, these are the things I'm going to do. And it could be as simple as telling yourself your favorite story that you know the details, so there's no surprise ending. But you have to use a little bit of energy to focus, and then you hope that sleep kind of sneaks up behind. But also, if people are lying in bed for 30 minutes and they're not asleep, they should physically get out of the bedroom and do those kind of non-alerting things, whether it's reading in a dimmer light, listening to music, something that they're doing in the other room until they start feeling like they're sleepy, and then go back so that you don't pair the sleep environment with anxiety, so that you don't get that subconscious, those alerting forces to like, oh, I see the bed, it's going to be another rough night. You got to break that cycle. And that's why it has to be in kind of another room.
So it's interesting. Whenever I've had trouble sleeping, and if I really, really like, I do all the things. I'll take melatonin, I'll take magnesium glycinate, and there's just some nights where I feel like it does. And I think women are just so good at using their brain. It just feels like
Mhm.
I call it like the mouse wheel. It's like
Mhm.
you're spinning, and you might just over and over, and you can't seem to like stop. It's like almost
Mhm.
like you can't stop thinking. And
Yeah,
like you
yeah.
said, it's like you could try not to think, but like it's almost impossible, right?
Mhm.
So
Exactly.
I have found that it is helpful to I'll just put on like a podcast or a book. And it's funny
Mhm.
because you think to yourself, well, Teresa, you're just going to be thinking more because you're, listening to something and learning. But the weird thing is that it makes you fall asleep. It's almost like you said, you're like using your brain energy to do something that it wasn't doing in a vacuum of thought, and it like calms the brain down. So I guess does that make sense for what you
It
were saying?
does.
Yeah.
Yeah. Yeah, absolutely. Because then uh, obviously people have to pick what sort of podcast. You don't want a murder mystery or something with a surprise ending or changing tones. That's why a lot of those apps now to help people sleep, they kind of speak in monotone if they're reading. And so, yeah, you can absolutely choose something so that your brain is thinking a little bit, but it's not like that alerting factor or suspense. Yeah.
That makes total sense because I tell you what, whenever I watch, if you guys out there have ever watched like medical shows, like the recent one, Dr. Lynn is The Pit. I don't know if you've ever.
Oh, I
Yeah.
haven't watched it, but I've heard about it.
People
Yeah.
don't. It's highly graphic, and I mean like it's intense like in a way, and it's got so supposedly like super legitimate medical stuff in it. But I tell you what, no one can sleep after watching The Pit. If you got a sleep issue, don't watch medical shows. Like that is not the right way to go. Okay. So I want to talk about like what you said was the phases of sleep. And I think this is good because I get confused by this, Dr. Lynn. Like, it sounds to me like deep sleep should be the thing that you do the most of. But it's not. It's not. When I look at my aura ring, I'm like, oh, I only got like 45 minutes of deep sleep. That doesn't sound good. And I know I'm probably not getting as much as I should, but can you walk through like really what phases of sleep there are and like what the body or the brain, I guess, together is supposed to really be getting in these phases, in terms of like quality sleep?
Yeah, absolutely. And we base the stages of sleep off of, those sleep studies that happen in a lab where you're covered with wires with the EEG and muscle sensors, heart rate sensors. And so when it's been transformed into the wearables like the Oura Ring, or there's, Fitbit, a lot of different ones out there, it it kind of instead of so many different types, like we've got of the non-dream phase, we've got stage 1, 2, and 3, and then we've got dream. There used to be stage 4. They kind of got rid of that a while ago. Um, but when it goes down to the wearables, they kind of just divide it into deep and light sleep. And so you get these different categories. So in um, like in a lab setting where we can really measure the EEG, the deep sleep should be only about 20 to 25% of the night. The more sleep deprived you are, then your body's going to recover deep sleep first. So it might be a little bit higher, but when we see go with a lot of it, then we think, oh, they must be really sleep deprived. But really, so think of just like a quarter of the night or a little bit less. Dream state also should be about 20 to 25% of the night. And then the rest of the night, so you've got another 50%, is the lighter stages of sleep. And so, um, yeah, one of the things when the wearables came out, we were getting like a lot of people that wanted to see a sleep doctor because their wearable was telling them that they were bad sleepers, but they thought they were fine. And it turns out, yeah, you are fine. Yes, yes. It's so it was kind of a transition in the period of sleep. I mean, they are really good for like looking at trends, but if you can get a quarter of deep sleep, and deep sleep is when you're going to have kind of like the lowest blood pressure, kind of the lowest stress on the body, hardest time to kind of wake someone up because they're in that such, relaxed state. And that's when like the heart cells turn over and repair. That's where again, the kind of the muscles, the tendons, the aches and pains. If you wake up somebody frequently throughout the night, you can kind of make them wake up achy. And so it's really a time to recover the kind of the tissues. Whereas the dream state, that's where, we kind of have a semi-paralyzed body, so to speak. We don't actually even thermoregulate, so kind of more like those, cold-blooded animals. You can't adapt to the temperatures, so the body's not going to go into dream state if it's really hot or really cold. But that's where the brain starts putting together new neuronal connections. So it's where you start learning, thinking outside the box, where it's going to put things together that normally wouldn't go together, trying to solve a problem. So this is where like problem solving for like mood is improved, cognitive function is improved. And again, that should be about 25% of the night. And it's also at the end of the night. So if you wake up early, you may not get into that last stage.
It's very interesting. Okay,
Did that
so
answer your
oh yeah,
question?
yeah,
Okay.
Teresa says yes. Okay.
Okay.
That's super helpful because that's true. I mean, that always confuses me, but that is very surprising that when you're in deep sleep, if there's a lot more of it, it really would mean that that person was very sleep deprived, which that would be what you would assume might be opposite. So that's
Mhm.
important for us who do wear Aura rings or Fitbits, just to know that. Okay, so we talked about those different phases of sleep, but what about different types of insomnia? We hear even
Uh-huh.
about if are there different types of insomnia and what are they? And even women who might even have blood sugar issues and they're waking up in the
Mhm.
middle of the night. Maybe we could talk a little bit about that too.
They used to kind of really try to tease out the different types, and now sleep medicine has kind of lumped them into chronic insomnia or short-term insomnia of less than, if it's just for a few weeks from it's related to say a death in the family, a trauma, that's going to be one thing, as opposed to, if it's going on for more than 3 nights a week for 3 months, then it's considered chronic insomnia. But there's still different types of triggers, that there can be. Usually someone can have the predisposition, but then have a precipitating factor, and then something that keeps perpetuating it. So sometimes we look at where can we kind of intervene on that. The ones that have been lifelong are usually a little bit trickier to certainly treat. Again, if you have someone with lifelong, sometimes it's good to kind of go back into like, was there a trauma, especially in the middle of the night, that's they want to sleep with the light on, so that things don't happen. That can be a little bit trickier, and certainly would need some counseling for that. But usually it's, I think with women, where we're talking about, they just kind of take on a lot of stress, always trying to do a lot of things for a lot of different people. So having that kind of wind down time is really important. I think the other ways that people sometimes can break it up, is it sleep onset or is it sleep maintenance, but that also usually gets kind of blurred as well. So I think that's where kind of a lot of the things that we do for insomnia would kind of treat both of them. So I think that's why we kind of put a little bit less emphasis on teasing out and putting different labels on what type of insomnia it is.
Dr. Lynn,
I, Yeah,
Yeah, have a follow-up question, but before I do that, I just want to take a quick break for our shout out for our podcast sponsor, We Heart Nutrition. One thing I want to share with everybody is We Heart Nutrition just released a couple of new products. One was a probiotic, and I just started taking it. What I've already noticed is like my bowels are regulating really, really well. So I am really pleased with that. And then they have an immune support supplement too. So two new products from We Heart Nutrition that I'm really pumped about, especially going into the sick season, right? Flu season, as they say. Like we really want that immune support. So take a look at We Heart Nutrition for all of their incredible products. And again, using the code GENIUS, you can get 20% off your first order if you use our code GENIUS at weheartnutrition.com. So please check out our podcast sponsors. So Dr. Lynn, I want to take this into the what you mentioned was stress. And so I think there's not a person out there who's a woman who doesn't feel like stress is a part of their life. Obviously, some more worse than others. But talk to us about cortisol in relationship to sleep and where cortisol can kind of get, out of its nice, perfect diurnal rhythm where we wake up with nice cortisol levels and it slowly decreases through the day. In sleep, where can cortisol go wrong for women, and what is the mechanism through stress that kind of causes that issue? And is there a relationship between perimenopause and menopause in cortisol and making their sleep kind of that 2 to 3 a.m. awakening? I'm wondering about that too, like in relationship to hormones and cortisol.
Okay, so the um, kind of where we set our internal clock, so our kind of master circadian pacemaker. The three ways we know kind of where our internal clock is by the cortisol curves, the temperature curves, and then certainly light will have an impact on it as well, and so the melatonin curves. Um, so it's supposed to be that your your cortisol is starting to rise before you wake up, and so that it's at its highest point right when you wake up. Because as I said before, you want your blood pressure really low during sleep, but then if you wake up in that state, your blood pressure is going to drop more. Dizziness, etc. And then it should be lowest when we're trying to go to sleep. So definitely if people are anxious or with the stress, then you can have it rise and be higher at night. Um, Other things that can certainly add to um, kind of the alerting factors or more of the adrenaline happening is if people do have sleep apnea. As you can imagine, when the oxygen drops, you certainly get this boost of the adrenaline to kind of wake people up. Obviously, it's a protective insomnia. And so that is one of the things. Sleep apnea is so under-recognized in women that a lot of times things get blamed on the adrenal glands. And I really think that they're either getting not enough sleep so that they're sleep deprived in that way, and then stressed, and then they're relying on their adrenal glands to, keep up for not getting enough sleep, or they have something in their sleep, such as their oxygen's dropping and nobody knows about it. The other thing, they've also seen some changes when people have restless legs, where it's just so broken up that the body doesn't get that healing time, and so then they work the adrenal glands a little bit more. So I know that's not specifically what you're saying just about the cortisol, but that's kind of the background where I think that it comes from. I do think that there needs to be more studies on the impact of sleep and cortisol. It's interesting that you'd said that. I was just thinking that's where we need to do our next systematic review. The managing editor of the new Journal of Restorative Reproductive Medicine. We're looking for different articles, and I think that is one that I'm going to embark on. So maybe I'll have a better answer for you in a year, but we do need to know more about it. And it's not all just about the adrenal gland, but what's making the adrenals feeling so stressed. And again, I think could both be sleep deprivation as well as undiagnosed sleep apnea would be my two bigger ones that I'd want to look at if it was specifically sleep.
So, Dr. Lynn, let's say a woman comes to you. She's a patient of yours. She's, again, really struggling with sleep, and we're kind of knocking out all these things. It's not the sleep app, the hygiene, yada, yada. are there labs that you would run for her? So I'm thinking about like as our listeners are listening to the podcast, hopefully they're able to fit themselves into one of these categories. I hope like giving them some sense of their next step. First maybe they're thinking about again just the basics of sleep hygiene. Maybe they're thinking about, oh my gosh, I do wake up in the middle of the night and I need to look into sleep apnea. They're kind of hopefully ticking through these check boxes. But let's say, there's a big question mark. When do they go to the doctor? And then what kinds of labs do you recommend them asking for?
If they've kind of checked off those things, but if there's daytime dysfunction where they feel like it's either hard to stay awake when they should be awake, with driving, um, really hard to get through the day, especially if they have morning headaches. I think that's a big tip off. Um, then I would recommend at that point that they go to a sleep doctor. Certainly don't want any women, sleepy when they're driving or if they have high blood pressure. So even though like sleep apnea is not that common in women in the reproductive years because the progesterone, is a respiratory stimulant. The the incidence goes up to kind of match men when they go through menopause. Usually there's a little bit of weight gain, but also the tissues are a little bit softer that they can close off, but also they don't have that progesterone to be the respiratory stimulant. So those are times when I would recommend going to the doctor. And the first test that they're going to do is going to be a sleep study, which the home studies now are so easy to do. There's things that look like the Oura ring, but of course they're adapted so they can pick up the faster change in the oxygen rather than averaging it out like some of the wearables do. So we can really see those kind of dips. And that can be, sometimes it's just reassuring to know, okay, I just have to work on getting the sleep in order through like CPTI. That's what we would recommend. It's definitely best with a counselor as opposed to just doing it on their own, but mostly that's accountability. So if they have a good, health coach that can say, okay, did you follow up? Did you actually do the charting? Because it's that charting that kind of reveals the pattern of kind of helping them to know where is the next spot that they need to focus. Because I think everybody in this field knows that like you when women come in and they haven't learned how to chart, they can just say, oh, I have kind of regular cycles. I don't think there's a problem there. And then they chart and then they see all these problems. The same thing happens with sleep. Fortunately for sleep, it's usually like kind of doing a little bit of intense record keeping for a couple weeks, and it's not, for years. Um, the labs, that would be the same as what we would be doing, like any good primary care is, looking for the thyroid, making sure are they, how's their sugar levels, their insulin levels. Kind of, it's not like any specific things. Like we don't check melatonin or some of the like kind of sleep type of things. So it's really just that kind of that baseline, making sure you're not missing some of the other things. Certainly, insulin resistance, metabolic syndrome is in the focus so often, and definitely sleep apnea will increase that risk of having metabolic syndrome. So yeah, it's not any really specific ones, unless, again, as I mentioned before, if somebody has restless leg syndrome, definitely ordering the ferritin. And you want the ferritin above 50 at least. And whereas the normal range can start at 20. But if someone has, where they're repositioning a lot. In kids, you can just have where it's not quite restless legs, but it's where they're just making lots of frequent movements. And that also seems to be iron related.
I'm glad you brought up the iron because iron deficiency obviously is super common in women, especially those who are menstruating, right? And I think it's really important that you brought up the cycle charting, Dr. Lynn, since that is what we do. We really recommend in the Hormone Genius podcast that women are aware of their body. And I think, with sleep, I would imagine many women, I think I've noticed this in many women, is that in the cycle, it is that luteal phase that can be more difficult for sleep. And I want to know if you think that's in relationship to progesterone. Is what we see that drop in progesterone does affect the relaxation of the brain? Is it that having low progesterone could also make sleep more difficult in the luteal phase? So from a cycle charting standpoint, what can we learn about women in terms of the sleep in relationship to their cycle pattern?
Yeah, it's a great question because the progesterone is going to work on the GABA receptor similar to like most sleeping medications do. And so, and we can even see when someone is having like an in-lab sleep study, you can actually tell on the EEG if she's got progesterone in her body or not. It changes some of the sleep spindles that get heavier. And um, and I've had women who have had PMS, and that was kind of their worst time. We know that's associated with the lower progesterone levels. And then when they had the progesterone, they felt like that suddenly from the worst phase of their cycle for sleep became the best time when they could sleep. And I've had several who said, "Oh, I can't wait to get to the luteal phase so I can take my progesterone because it helps me sleep so much better." So it definitely can be right, a clue that they should be looking into, like, do they have those other symptoms of PMS or other things that would make us think of low progesterone? Because it can definitely help with that added.
And what you had said earlier too, and again, I'm glad we're talking about progesterone because it's such an important hormone. And it's important to understand, ladies, if you do, if you're charting and you see, a limit to number of days after ovulation until the day before your next period, averages around 12-ish. Just be paying attention to that. And again, if you're not already working with a charting instructor, we encourage you to do so. Especially if you're having trouble sleeping. I mean, two birds, one stone. Understand your cycle and kind of get a sense of when that sleep difficulty is taking place. But Dr. Lynn, when you mentioned the low ferritin and having a hard time sleeping, what's interesting, Teresa, I don't know if you remember this. It was during Seek of last year. I think we were sharing a bed, remember? And I had no idea. Or maybe it was the summer when we were having our brain day, but apparently I was moving constantly in the night. I had no idea, constantly. Right? Do you remember that, Teresa? And I did get blood work and I had a 4. My ferritin was a
Oh,
4. And again, zero clue. My period's super heavy, all the things, but I just now as you said that, it's all coming together. And so I had a couple um iron infusions and now I'm feeling much better. But it's just
excellent.
yeah, I just was putting that together and Teresa, I wanted to know if you remember that part.
But
Okay.
that is a
Yeah.
great point that usually we think of if it's if low iron is going to be causing the trouble with the sleep that women feel it, but they get so antsy and they can't keep their legs still before they fall asleep. But there is periodical limb movements of sleep where it's just happening in the sleep where they may not know, but then they get much better sleep once it gets replaced. And a lot of people do need the infusion rather than just taking it by mouth. So we certainly try the oral iron for 3 to 6 months, but if things aren't getting better, then it's time to consider an infusion. So I'm
It,
glad you brought that up. Great.
It is
totally. And
also, yeah, and Jamie, I do remember that because of course, it disrupted my sleep, and that's another factor, right? Like, if you sleep with somebody who has already disrupted sleep, then your sleeping probably worse too. So we have to think of like,
Exactly.
and I asked my husband, I was like, Justin, Teresa told me I was having I was moving all around. I'm like, do
yeah.
you recall? Like, does this ring a bell? And he's like, no, I don't. I'm like, what? So this is all coming full circle for me, Dr. Lynn, personally, in my own personal life.
But it
Uh,
is funny how so many women come to the sleep doctor after they went off on a trip with girlfriends because they just pay
oh,
attention to sleep more. Yeah.
crazy.
Mm.
So cool. Okay, ladies. Well, if you wonder, just like going overnight. I'm sorry, husband and family. I need to have a girls' night and really see if you're struggling there. But okay, before we kind of start wrapping up, I really want to know, this is such a specific topic, an area of health. Dr. Lynn, do you have a personal story or is there a reason why you focus on this very important topic? I'm curious to know that.
Well, originally, what moved me into going into sleep medicine was really because I had 4 kids, and it was a lot easier than being on call, for the hospital in the evening and the weekends. Um, but then I just fell in love with the field of sleep because there were so many lives that we could see change that when I was teaching primary care, people don't come and say, "Oh, thanks for putting me on the blood pressure pill. I feel great." And no one does that. But when you change their sleep, they say, "Oh, you've changed my life. I'm so grateful." And it was like, "Oh, we're making a difference where when I started 30 years ago, there wasn't as many people focusing on sleep. And so it was a real need." And then uh, but I had been doing restorative reproductive medicine, NFP only from the time that after I graduated from or finish my residency. And so kind of one of the key patients, I think, that made me see the importance of both restorative reproductive medicine and sleep medicine was a woman. She was kind of the poster child for PCO. She was short, she was overweight, thick neck, and she'd had like constant bleeding. She brought in her Creighton charts and she faithfully put on that red sticker for like two charts, for a year. And she'd had two or three ablations and it always came back. And no one had really addressed the charts. She said people would kind of like, oh, okay, that's fine. We know you're bleeding, but not really looked at it, which I think several women still probably have that happen. But also they'd never asked her about her sleep because she was in her 20s. And she had severe sleep apnea where she was dropping down to her oxygen saturation was in the 50s during the night. She was holding her breath about 60 times an hour when she was asleep. And then also, obviously, her progesterone was really low with the PCO. And so we cycled her progesterone and we treated the sleep apnea. And it wasn't till the sleep apnea got treated where the oxygen levels were brought up that then the endometrial lining could be healthier. And then she went to like a normal cycle from bleeding for years and multiple ablations. So I think that's the why really got me excited about combining the two, because I think so often in women, people aren't looking into sleep disorders in them. And this one made just a complete difference in her life.
I'm so glad you brought up that story. And it just shows you that, I mean, Jamie and I talk about this all the time. We are not just one part. We're not just a uterus that bleeds. We're a whole person. And so often, again, we put these symptoms into silos. And so it's like you just treat the symptom as a medical professional, but you're siloing the person into like just that instead of actually addressing the whole person, which that story perfectly demonstrates how in addressing the whole person and looking at them as like what else is going on, what else is happening in your body so that we can put the pieces and the puzzle together to make you whole again. And so that's such a great story for that. And I'm sure you could tell a lot more. And I just love how you're able to I just think people wouldn't realize like you could take a Creighton model chart and like relate it to sleep medicine. You know what I mean? So I feel like that's such a beautiful kind of thing that we've never thought about. And so in relationship to that, before Jamie asks, we're wrapping up, I do want you to quickly touch upon fertility and infertility maybe, and kind of like how important is, or what do we know about infertility in relationship to sleep medicine? Is there a link between patient sleep and their ability or inability to get pregnant?
I'm not sure I can wrap up that question in a in a quick summary, but I will try. Um, because we know, like for women that have been charting, if the body feels like they're at risk, if there's either stress, whether it's, emotional or physical, or they're not healthy, then the master pacemaker is going to say, okay, it's not time to have a child, and you see the longer cycles with, kind of the stress induced. And so the way that sleep can impact infertility is obviously if you're not getting enough sleep, then the body's going to say, this woman is too tired, it's not time to bring in another child. So trying to aim for that 7 hours. But then also, again, if there is sometimes that sleep deprivation is like the husband snores so badly that she can't get the deeper sleep or the other sleep disorders that we were talking about. My colleague in sleep medicine, knowing that I, also do restorative reproductive medicine, he said, hey, this CPAP is a baby maker. I think he'd had one or two patients that when they got the man on sleep apnea, they'd been struggling, and 2 to 3 months later, they were pregnant. Just because I think the woman had, more sound sleep, as well as it bumps up men's testosterone, or that can be one cause of the low testosterone is if men have sleep apnea. So I think it was probably a combination of the two. The other thing, though, that I think is a really key part that I want your listeners to know is some of the brilliant research that Joy DeFelice did with sleeping in the dark. Like one of the reasons we know melatonin is important for sleep, but it's also important for progesterone because melatonin is an antioxidant, but it will upgrade one of the proteins that's needed. It's called the star protein. That is the rate limiting step for progesterone production. So she showed that if you just have women really eliminate the light at night, so that you want to, again, aim for that good 7 hours, but you want it to be as dark as possible, like not seeing your hand in front of your face. And that will raise your body's natural production of progesterone. But it's also better to do it that way than to take a melatonin supplement, because just like you wouldn't give progesterone in the follicular phase because just the receptors aren't there, you want it to everything, like sleep can be like a symphony, just like the menstrual cycle can be. You want everything to be at the right time. And so if you just make the room dark, that times it with all the other inner factors that control our clock, so that you get, the right hormone at the right time, and it'll bump the progesterone production. And she's seen a significant improvement in both like abnormal bleeding, miscarriage rates, and infertility, just by people having that focus to make it as dark as possible. And sometimes when a patient goes to, a physician to looking up infertility, there's so many things that they want to cover that they don't always emphasize that. I think that's where sleep coaches, the hormone coaches can make such a difference. It's just making sure that is the room dark, and then having them look around after 5 minutes of, when your eyes get accustomed to the dark. It's like, okay, which light, which clock is glowing, or there's too much moonlight coming in from the windows, or, what do they need to do to change it? But I think that needs a lot more research, but the research that we have really is impressive.
And you know what? Free.
And free and healthy. Yes.
And healthy.
Yeah.
It's free,
Yeah.
it's healthy. That's so interesting. I feel like our human condition, if we have a complicated problem, it seems like we need a complicated, like the answer is complicated, but in reality, sometimes the answer is simple. And we overcomplicate. And again, it's just, I think, the complexities of the human mind. So hopefully this episode is giving our listeners plenty of tools and strategies to try, especially if you have suffered from sleep, if you are struggling with infertility. And again, I love the story you shared about your PCOS client or patient, because that's just incredibly empowering, and knowing that, again, just healthy, good sleep should be a priority. So, Dr. Lynn, as we wrap up, I'm going to ask you the question I ask every guest on our podcast. What do you wish every woman knew about her hormone genius?
As you said, sometimes we make things more complicated, and we really need to focus back on the basics more of just those 3 pillars of getting, good sleep, good diet, good nutrition. And sleep often gets the back burner for women, and I just want them to move that up a little bit more, and remember to make it dark when you're sleeping.
Remember to make it dark. That is it's such a funny thing to say. Remember, just make it dark. All right, gotcha. All right. Well, Dr. Lynn, how can people get a hold of you? How are you helping patients still, or do you have a practice? Give us all the details of kind of like where you're at.
So I'm now retired from my regular job where I was the program director of a sleep fellowship, and so now with my more time to volunteer, I'm the current president of the Institute of Restorative Reproductive Medicine of America, and we have an upcoming conference that will be a virtual conference that will be January 30th and 31st. On the 30th, we're going to do what is RRM, because we know at this time in our country, we need more doctors to actually look into this. So this would be kind of aimed for those brand new to the field. And then on Saturday, we'll have some great keynote speakers that I think will help those that are already in the field to kind of boost their knowledge and build camaraderie. And so our website is irrma.org, and that'll have all the details.
Awesome. Well, we'll be sure to put all that information in the show notes. Thank you, Dr. Lynn, for being with us and teaching us about how important sleep is, and how important restorative reproductive medicine is, as well as this is a growing field that we're really excited about and will continue to shout out on our podcast. So thanks so much for being here, and we will talk to you soon.
Thanks so much for having me.
Thanks for listening to the Hormone Genius podcast. Please remember to share our podcast with your friends and family, and also follow us on social media. If you were not aware, we have a YouTube channel. So if you could like and subscribe to our YouTube channel to stay in the loop with all of our latest episodes, we would appreciate that. Thank you so much for your support. We are excited to journey alongside you as you discover the beauty and the genius of your hormones.